Hi, and thanks very much for coming to listen to this presentation on physiotherapist-led management of FAI syndrome. It's great to be here virtually, although it would have been very nice to be able to do this presentation face-to-face. So what I'd like to do is, if we're trying to weigh up what options our patients should be using, I think it's really important that we have an understanding of what best practice treatment is. So I'd like to talk about what we could use to inform best practice physiotherapy treatment for femoroacetabular impingement syndrome. So we can go to the consensus recommendations. We can also consider evidence from systematic reviews. We can look at what knowledge we have of physical impairments in these patients. And then lastly, we can listen to patients' voices because patients always have a lot to tell us. And together these things can give us an understanding of what best evidence physiotherapist-led treatment for femoroacetabular impingement syndrome looks like. So let's firstly look at what consensus recommendations say. So we were part of the consensus recommendations from Zurich, which were published in 2020 last year in BJSM, where we looked at what physiotherapist-led treatment for young to middle-aged active adults with hip-related pain should consist of. And the first recommendation that we made was that exercise-based treatments are recommended. And so our take-home message from this was that exercise should be the cornerstone of all of our physio treatments, and we should be targeting impairments and dysfunction. And that the things that really should be include lower extremity and core muscle strengthening exercises, motor control exercises. We should be focusing on dosage and progression, and we should also include some range of motion exercises. We also recommended that exercise-based treatments should last at least 3 months. And I'll look at the evidence for that a little bit later when we look at systematic reviews. The next recommendation was that patient-reported outcome measures, measures of physical impairment and measures of psychosocial factors should be used to monitor patients' response to treatment. And so that patient-reported outcome measures such as the HAGOS or the IHOT-33 are really suitable to use in this patient group. But we can also monitor progress by measuring things like hip muscle strength with dynamometers and range of motion to see whether or not patients are responding to treatment the way that they should. Our next recommendation was that these patients should all be doing physical activity, which may include sport, and that we should be developing a plan early on for return to physical activities, and we should be looking at Claire Ardern's work in helping us plan return to sport programs for these patients. The next recommendation was that as clinicians, we should be discussing patient expectations and use shared decision-making and provide education for patients to help them make the most informed and best choice for them for their treatment. And so patient education should be looking at things like the relationship between pain and hip joint structure, the prevalence of intra-articular findings in both asymptomatic and symptomatic people, because we know that they're actually quite high in the hip in asymptomatic people, the associated risks of both surgical and non-surgical treatment, and what we can expect in terms of magnitude of improvement and duration of treatment for both surgical and non-surgical treatment options. And that this should all be done under a shared decision-making framework. So the next piece of the puzzle that we can use is we can go to the systematic reviews that will help us inform what our treatment should look like. And we published this systematic review in BJSM last year. And what we did first was we looked at the between group differences for physio treatment compared to sham physio treatments or no treatment in non-surgical populations for treatments that lasted for 6 weeks. And what we found is that the physio interventions when they were 6 weeks duration were no more effective than control interventions in these patient groups. We then looked at what happened for physio treatment programs where they were of 3 months duration, and the results were a little different in that the physio interventions which comprised of strength and range of motion and functional retraining were more effective than control interventions for function when the treatment lasted for at least 3 months. So it seems as though treatments that last 3 months are more effective in these patients. But it's important for us to remember that in our systematic review, we only included pilot studies because there were no full-scale RCTs of what best practice physio treatment should be. But we are hoping to publish the results of our full-scale RCT on over 150 patients sometime in the next 12 months, and that'll help us answer those questions on what best practice physio treatment should look like. So then we can then take our knowledge of impairments. And I think when we're thinking about impairments, as physios, we're really good at looking at the bio in the biopsychosocial model, but we should also be looking at those other psychological and social elements as well. But let's firstly look at what we know about the bio in the biopsychosocial model when we're looking at patients' impairments. And this consensus paper basically summarised the physical impairments that young active adults with hip pain have, that was led by Andrea Mosler. And what we found in this paper was that patients with hip pain commonly have muscle weakness in all of their hip muscles. Interestingly, they also have reduced power in their hip flexors and extensors, and they have weak trunk muscles as well. There was a little bit of discussion around whether or not they had reduced hip range of motion, but everyone agreed that the evidence showed us that these patients also had poor functional performance, poor balance, poor movement control, and really poor plyometric or ability to jump and land. And that their physical activity capacity was also significantly reduced. So if we now go to the psycho component of the biopsychosocial model, what my colleague Marcela Pazanato found was that she looked at kinesiophobia in patients with ephemeroacetabular impingement syndrome. And this is unpublished data, so this paper is currently under review, so please don't share it. But what Marcela found was that kinesiophobia related to poor self-reported clinical outcomes, but not to physical function in people with FAI syndrome. So in this paper, she aimed to explore the association between kinesiophobia, which is being afraid to move, and quality of life and pain and physical function, and then also to see whether the fear of movement was different between men and women. So this was a cross-sectional study of 150 people with FAI syndrome who hadn't had surgery. So we measured kinesiophobia plus a bunch of other patient-reported outcomes and a whole lot of physical impairment measures. Excuse me. And what we found was that having more kinesiophobia, so being more frightened to move, was associated with worse quality of life, worse physical function, and greater pain levels, but not with the actual physical performance. And that in women, kinesiophobia explained a lot more of the variation in quality of life than it did in men. So kinesiophobia seems to impact women more than it impacts men. So fear of movement is associated with worse pain and function and quality of life. And these are probably more pronounced in women than in men. So the other paper that's really looked at the psychological impacts of hip pain was one that was published last year in BJSM. And what this paper did is it included 16 people who were on average age 51 who had been to see an orthopaedic surgeon for their hip pain. And they found that most people believed that their pain was caused by exercise. They all believed that they had damaged hip structures, and this seemed to be potentially an inappropriate interpretation of their imaging findings. They all described multiple ineffective treatments, and half of them believed that they had no control over their symptoms, so that they were not able to modify their symptoms at all, and this was having a significant negative impact on their mental health. So this psychological study again showed that fear of exercise and fear of further damage creates a really complex interplay between the physical and the psychological impairments that patients with FAI syndrome have. And then I think the last element of the biopsychosocial model to talk about is the social impacts of FAI syndrome and people's ability to actually access physiotherapy treatment. And this is where the fourth element of our puzzle, or the patient voices, come into play. And again, this is unpublished data that we're currently writing up, led by my colleague Millie Bell. And this is a qualitative study of patients' beliefs of what physiotherapist-led treatment for FAI syndrome should comprise. So again, I would ask you to not share these results because they're unpublished. And what patients told us is that they want to know what the cause of their hip pain is. They wanted to have their imaging findings clearly explained to them. They also wanted to have a good understanding about expectations and prognosis, and they wanted to know this early on in their physio treatment. And they wanted to know how often and for what duration physio treatment would be required. Interestingly, they also were interested to know whether or not they could avoid needing surgery for their hip. When we asked them what a physio program should look like, they told us that the physio program should be at least 2 to 3 months duration, and they were prepared to do it for up to 6 months. They were prepared to do on average 3 exercise sessions a week. They were happy to pay for a gym membership if they felt like it would complement their physio. And they had a really strong expectation to be able to return to sport and activities that they previously couldn't because of their hip pain. They felt the barriers to treatment access included competing commitments. So they were busy people, they were studying, they were working, they had families. They found coming to face-to-face appointments regularly could sometimes be a challenge. And often they lost motivation to be able to stick to their home exercise programs. And a lot of them didn't have access to the space and the equipment that they needed to complete their exercise program effectively. But they felt that technology such as telehealth, videos and apps and messaging reminders could really help facilitate their physio treatment. They wanted to have a really good ability to plan treatment to fit into their busy lifestyles. They wanted access to equipment. And interestingly, they were quite happy to use over-the-counter medications to help manage their spikes in hip pain if that was stopping them being able to exercise. So if we take all of those 4 pieces of the puzzle together, then what should we be including in our best practice physio treatment for FAI syndrome? And these are the key components that when we take all of this evidence, we should be putting into our treatment programs, where we're looking at hip strength, trunk strength, functional plyometric and balance retraining, movement retraining, cardiovascular learning or physical activity, and also a lot of education and counselling and shared decision making. Now, what we're going to talk about now are, because of the interest of time, we don't have time to go through all of these components, but I just wanted to touch on cardiovascular learning and the education, because I think they can have a really big and positive impact on all of our patients. So with our cardiovascular loading, what I would really encourage you to do is to start patients on a progressive cardiovascular loading program, where they start with low impact, high intensity activities, so they feel safe, that they're not going to cause more damage. But eventually we get them back to the type of activity such as running with speed and direction change that they want to do. Now, with our physical activity or cardiovascular loading programs, we can progress duration, intensity and complexity of the activity, but we should only be progressing probably one element at a time by approximately 10%, so that patients do feel safe and don't feel like they're being pushed too quickly when they're not ready. But we can allow our patients to progress if their pain is mild. So we don't expect them to be pain-free. It's okay for them to progress when they have mild pain and when their perceived exertion is in the moderate zone. And then the other element that I'd really like to cover off on is education. And so we should be informing our patients about the poor relationship between structure and symptoms, recognising that structure may be important in some patients, but it's not necessarily important in all of them. We need to tell our patients that they need to maintain physical activity throughout the rehab process, that they will have flare-ups of symptoms and they won't be pain-free with exercise, but an acceptable level of pain of around 3 out of 10 is okay. That they do need to continue to do an exercise program, but if we can try and normalise that as fitness and not rehab, then they're more likely to buy into that as part of their, going to the gym 3 times a week. We can sometimes modify their impingement positions during ADLs so that they're not spending as much time overall in the impingement position, which might allow them to go into that position more comfortably when they're playing sport. We need to help them work out how to fit their exercise routine into their lifestyle. And I think really importantly, encourage them to understand that they will definitely improve with treatment, but they are unlikely to get back to the same as a healthy age-matched control. And that's actually okay, because that's something that can be managed. So lastly, I'd just like to cover off on what I think some of the pitfalls for physio-led treatment for FAI syndrome are, the things that as physios we need to get better at. We don't have any full-scale RCTs of best physio treatment, as we've already discussed, and that's a big barrier that hopefully we'll answer soon. We also don't have any standardised approach to best practice physio treatment either. Physios love to argue, and those of you who are on social media will know this, that there's a lot of squabbling about what best practice physio treatment should be. Whereas I think our surgical colleagues have been a lot better at becoming very standardised and all being on the same page about how surgical treatment should be done for this particular patient group. So as physios, we need to stop arguing and come up with some standardised approaches to best practice treatment. I think as physios, as a profession, there is a tendency for some physios to want to become gurus and to sell a particular treatment approach that is their treatment approach and is the only way to do things. And that doesn't necessarily advance science, because often these gurus develop treatments that are not formed on science. So lastly, our take-home message is that we do need full-scale RCTs for best practice physio treatment. We need physios to work together and develop standardised and effective approaches and leave our biases and leave the guruism behind, because this will give both surgeons and physicians and patients confidence in the physio type of treatment that these patients will have access to. We also need really effective ways to scale up and implement effective physio treatment, which we don't have at the moment. We need good decision-making tools to help stratify patients to optimise care pathways, so we know which patients are going to benefit from physio treatment, and we have a better understanding about which patients might be better having a surgical type of treatment. And lastly, we really need to listen to the patient. Not all patients want surgery, but not all patients can commit to or afford the 3+ months of physio treatment that they require. And so we need equitable funding models to give patients access to the treatment that is going to be best for them. So thank you very much for your attention, and I look forward to speaking to you shortly in the panel discussion.